Good evening, dear friends. I'm happy to be back here at the Orthoregen Journal Club. So thank you, Caro, Andre, for inviting me and having me back again. The question was, would I be open to have a bit of a conversation about a paper we published this year? And as you can see, there were a couple of dear friends from Unimax representing the university at this paper. This paper was the result of a keynote lecture I gave last year in August 2024 at the San Diego Academy of Regenerative Medicine, and they asked me to discuss PRP and the combination with adipose tissue stromal vascular fraction. And based on our earlier conversations, I took the liberty, together with my fellow authors, to add what we call a high-density PRP to the mix. And I will explain during this presentation what the definition of a high-density PRP would be. For those who haven't met over the last couple of years, just a very brief introduction about myself. I've been in this space for many years. Started my first case in 1989 and did my thesis in 2007, PhD thesis. Started to become involved in the wound care business, so I combined hyperbaric medicine with biological therapies. Was appointed international professor at Unimax. I'm very proud to represent Unimax at my conferences and my papers. I was part of the faculty at Harvard University and a course on biologics and pain management. Have been appointed as honorary adjunctive professor at the University of Queensland, one of the top 50 universities in the world with a very high ranking. And as of this year, I am also the Senior Director of Medical Affairs of Bioventus here in the US. It was my goal after my PhD to keep on doing research, to write reviews, to work with people in the field like most of yourself, and I made my promise, let's try to make one significant, impactful paper every year. So this is just a brief summary of what we did, and this is a summary of my roller coaster. And up until now, I was able to join or either publish myself over 100 articles on regenerative medicine, whether it's PRP, bone marrow, or adipose. To regenerative medicine. So what's going to happen if we bring PRP and adipose tissue together? So I think there are a couple of essentials apart from the indications that we need to know, right? So we're going to bring two biological products into the mix and make that a biological injectate. So with your permission, what I would like to do is spend a couple minutes on the introduction of high density PRP and adipose tissue being represented by tissue stromal vascular fraction. As you know, as most of you know, tissue regeneration, tissue repair, in general wound healing are very closely monitored processes of the human body. There are multiple cells involved, multiple pathways that ultimately should lead to tissue repair and to wound healing. So what we can conclude is that tissue repair, tissue regeneration is a well-orchestrated event of pathways. From a stimulatory perspective to the initiation of pathways. And if we want to do this, if we want to mimic nature, from an homeostatic response, we need to be very meticulous. We cannot say, I'll take some fat here and take some blood here and mix them together, and all of a sudden we have a very powerful autological product. That is not going to happen. So when you look closely at what the patients give us, then in this Dutch oven we have a ton of cells, right? And we can fill all of our plates with different biological products as you could use them in clinical practice. So the patient has a huge reservoir of different cell types, right? We can make PRP, which is the most common one. You can aspirate bone marrow. You can use it as an aspirate. You can use it as bone marrow concentrate. We can use the fibrin to make a matrix, a scaffold, and we have adipose tissue. And each of these different products, each of these biological different products, they represent different cells. So each of these products are defined by multicellular components, and well, let's call it a patient autobiological soup. And after 35 years, I still feel that we are still struggling to make this recipe book work very well. So when we look at PRP indications, that number is increasing. That number is increasing every quarter. And these are just the medical areas, right? In each of these areas, we got subdivisions. So for musculoskeletal pathologies, we can have an elbow, but the elbow has different pathologies and different tissue types. So depending on what the pathology is, what the tissue anatomy is, we might need to have different strategies. So this is just a general field for PRP, and the same really accounts for adipose tissue, whether it's a tissue stromal vascular fraction or collagenase adipose procedure. We also recognize a lot of cellular activities as well in sports medicine and orthopedic surgery. What are the variables? We need to be aware that there are different variables that have an impact on biological preparations, whether it's PRP, but also adipose tissue. Especially for, well, the patients. The patient is a huge variable, right? And then the physician as well can decide, okay, where I do want to harvest my fat, what harvesting technique I'm going to use. And then this picture here on the right hand side, the flank of a male patient is being used. So now we can debate about the harvesting sites. Is that a proper site? Is it an adequate site? Or do we maybe need to go to the lower abdomen? I have my personal feeling, but let's have that open for discussion during the questions and answering. Then there are many different systems on the market, from very sophisticated collagenase depending systems to emulsification, to filtration, to mechanical emulsification. So we have a lot of variabilities, but also, again, the biggest variable is the operator. Who's going to harvest, who's going to do processing, who's going to inject. So all of these different variables, and that ultimately contributed to the fact that in 2025, starting in 2026, we have no consensus. There is minimal regulation and there is for sure no standardization. So in the US, the FDA looks at, well, devices that are going to be brought new to the market. Is how does this device work compared to a existing device, to a predicate device? And based on these differences in cells, they're going to be used to measure the efficacy of the product. They're going to grant the product to the market. So it's not related. Any of these devices on the market is not related to efficacy, or is never measured towards patient outcome, only towards safety. So what do we know? When we look both at PRP products, when we look at bone marrow products, adipose tissue, then we can say that the entire device market is completely out of control, as well as the preparation protocol. So we get a ton of devices from a PRP's perspective and any other autobiologic perspective, with one firm conclusion: we have missing standardization. But all of these missing pieces in the device methodology and accepted standard ultimately will have a huge effect on patient outcomes. And again, we did a proteomic analysis almost 6 years ago, looking at the differences. It doesn't mean that these products are bad, but they are profiling a different profile of constituents, what's in there. So that was pretty clear. So the difference between one product and the other, well, could be a very significant factor. And that has been confirmed by a variety of papers, actually. So over the last couple of years, we have seen many papers on the market really indicating different outcomes. But the basis of every PRP preparation, let's start now with the PRP preparation, is the human blood, is the unit of whole blood. So platelets make up for the best and the most adequate definition of platelet-rich plasma. And maybe we should call it plasma rich in platelets. I mean, that's still open for debate. But one thing we do know is that inside all of these platelets, we have different structures. So the platelet by itself has alpha granules, dense granules, lysosomes. And it's only since 2 years that we really have a close, open eye on the presence of multivesicular bodies, or like a lot of people like to call them exosomes. And all of these different structures in the platelet, they have key content. So each of these structures, like the alpha granules, have growth factors. Not one, they have multiple growth factors in there. We have coagulation factors, we get angiogenic receptors. So the platelet is a very, very sensitive cell, first of all, that is capable of redirecting and being in control of tissue repair. And so each of these different cell types, they have different functions as well. And this is one of the graphics that we used in the paper we are discussing right now. And over time, when I first made this paper, this was a graphic paper I made in 2006. 2006 was the first paper, and I know Professor Lama recognized that picture from when he and I started to have conversations more than 20 years ago as what the power of platelets really is. And over time, we added structures to it. So initially, we're only focusing on growth factors, right? Like VEGF and PDGF and TGF. So those were the main constituents in platelets that we were thinking would make a difference in patient outcomes. Then a couple of years later, also when we did our scanning electron microscopic study, we found in the dense granules more structures. And others confirmed as well the presence of different molecules and cytokines, including the last couple of years the presence of platelet-derived exosomes and multivesicular bodies, where we initially thought that these platelet microparticles that we did recognize on the platelets were not defined as extravesicular bodies, as exosomes. But most likely what we noticed about 5 to 10, let's say 10 years ago, these platelet microparticles, they were already the exosomes, but we were lacking the methods to define it specifically. One of our favorite topics from my friends at Unimax and Orthoregen colleagues is to discuss white blood cells, aka leukocytes. This is just a simple representation of the white blood cells, what they do. We're not going to discuss it because I want to have a focus on particular white blood cells. The neutrophils, for example. Most of you will not recognize that neutrophils also have different phenotypes. So the neutrophil type 1 and neutrophil type 2 have different properties. They have different activities. And of course, neutrophils are inflammatory. They are pro-inflammatory, but it's only for a short period of time. After that period, after the pro-inflammatory phase, specific reparative functions have been cited, have been recognized with a different phenotype. That's in neutrophil type 2. So when we were more or less brainwashed in 2010 with leukocyte poor definition, leukocyte rich definition, we never paid any attention to the fact that neutrophils have a clear function in the natural healing cascade, which I'm going to allude to in a little bit later. Monocytes, we're well aware of monocytes. That's also another bond we have on the different phenotypes with each other and what they can do and how important they are, as well as the lymphocytes. These are the references to cite all these papers, and then I always show very proudly the differences between the leukocyte poor product and the leukocyte rich product with regard to monocyte and macrophage function. Getting back to that crowded market space, 2 great papers. They did a lot of testing of PRP devices. However, I think they forgot to take the most out of this graphic. So in other words, it has great details from a volume perspective, from a platelet concentration perspective, and from a PRP perspective. What this paper doesn't do is connect the dots. In other words, we have a baseline. We have baseline platelet concentration, we have a PRP volume and the PRP concentration. So we easily can calculate the dose. So the platelet dose is no more than multiplying the volume of PRP prepared with the platelet concentration in that PRP specimen. And that gives you the total amount of platelets that you can use for your patient treatments. And if you want to take it one step further, what you can do is you can calculate as well based on, well, how much volume did it take from a patient, what's the platelet concentration in the whole blood. You can calculate the efficacy of PRP devices based on that equation. I think we have some kind of a consensus among the proper definition of PRP, and that it has a platelet concentration of 1 billion platelets per milliliter. And Professor Mark, the Mandibulofacial Surgery, and my friend Shane Shapiro from Mayo Clinics, 20 years apart, they confirm now, if we want to have some clue on what is a good PRP product, then it should have at least 1 billion platelets per milliliter. Now, the goal was to combine our adipose tissue with high density PRP. So now let's have a deeper look at what it really is. So this is just a typical PRP device, and you spin it, a single process device. And what I like about this picture is you see actually the leukocytes, also known as the white blood cells. So you see that gray whitish layer. You see some RBCs, which might be arbitrarily, because with all the scatter of the cells, they could be very well be more platelets than RBCs. So based on the different densities of the and specific gravities and the size of the whole blood cells, after a centrifugation procedure with any device, as demonstrated by the paper from Alves, all of these cells have been organized in a very particular fashion. And when we then magnify it, then plasma would be defined. I'm sorry for the 110, it should be at the bottom here, but the plasma range and the platelet range and where all these different white blood cells are. So depending on what you decide where you would like to capture your buffy code, you can have either a pure PRP product, so pure PRP product would be between the black lines, would have no addition of red blood cells, would have no single white blood cell. So you're capturing only plasma. The leukocyte poor, as it has been defined, has a touch of RBCs, and what it means compared to the purest, you will collect more platelets. You will collect more specific white blood cells, in particular the monocytes and the lymphocytes. And then the leukocyte rich, our favorite of tonight, is in a deeper layer. So from very yellow to a little reddish flare to red, really brings in a whole different cascade of PRP formulations. And this would be a leukocyte poor product where there's just a little flare of red. So what it really does is you do not connect with the bigger platelets in there. So the more innovative approach would be the high density platelets, right? And the high density white blood cells. So the pure PRP, the leukocyte poor, the leukocyte rich are well defined. We want to add to that the high density platelet fraction. So in other words, the more dense, the bigger platelets are going to be deeper in the red blood cell layer because their gravity, their size is bigger, so they're going to be sunk in deeper in the red blood cells. So high density PRP would be, well, a little bit of plasma, but mainly a little bit more of red cells, capturing the most regenerative platelets. And we never looked at the literature, right? And let's be honest. I mean, these papers were published in the early days, which never surfaced initially in the non-surgical orthobiological medicine. But the conclusions of these papers are very, very profound, right? And it really means that platelets have different densities. It's not like the traditional assumption platelets after a PRP procedure are in this area. No. Platelets are going to be all over the place. They're going to be in the plasma, they're going to be in the RBCs. It's up to you as a doctor to decide what kind of platelets you would like to capture. You want to have the young, bigger platelets in the bottom, or you want to have the smaller ones in the plasma, which have far less regenerative potential because they are about to leave the circulatory system as they are have a very limited life cycle. So all of a sudden, we feel the discussion should get started between the innovative and a novel approach is capturing a different kind of platelets, capturing the platelets that are deeper here, and they are more dense, which we can measure with the mean platelet volume, and for that reason they have a higher regenerative potential. We submitted actually over the weekend this paper with a global author membership from Australia to Europe, America, South America, where we really got a good conclusion on the platelet volume and its density and what it really means in PRP. So we're very happy we were able to have a very significant authorship with Dr. Paul Harrison, Professor Paul Harrison, I have to say, from the United Kingdom, who is, I think, one of the world's leading hematologists with platelet function. And these are some of our conclusions that you will find in the paper once it has been published, where we anticipate, in fact, that with these higher density platelets, we're going to have more effective PRP preparation. But what does it really mean, right? That's the other question. We know, as we described in the paper, that we have two types of healing cascades. That's the classical healing cascade, but there's also the angiogenesis healing cascade. And they have overlapping functions, they have overlapping timing, they have overlapping cells, but they are very much connected with each other. And they work in conjunction. It's not like we have the classical healing and later the angiogenesis. No, they're intertwined. They work together in a very coordinated way. And this is my representation of a PRP natural healing cascade, right? So what you see is you have that PRP specimen with the bigger platelets in the bottom and the very small one up here. We have, first of all, a lot of platelets. When we have from a non-activated to an activated state, after you administer your PRP, the platelets become activated. In our ideal world, it has the neutrophils, it has the polarizing neutrophils, the inflammatory one and the reparative one, and then with the monocytes, and the monocytes have the different phenotypes of macrophages. So we transition from the initial platelet release burst with high numbers of platelets to the inflammation, so the leukocytes and monocytes start to play a role. And then at the end of the natural cascade of healing, mimicked by the use of PRP, we go to tissue repair, the proliferative phase, and ultimately to the maturation of tissue with a more dominant role of the lymphocytes. So if we would go back to the definition of leukocyte poor, then we would eliminate this phase. We would take out the neutrophils, and that would mean we have an interrupted natural cascade of healing. In other words, PRP does not mimic the natural cascade of healing because we excluded particular important white blood cells. And why is that important? Because in a paper 2 years ago, we already described very carefully the biological approach of diminishing blood vessels based on chronic conditions, right? So we are missing the vascularity because we're going to continue stimulation of negative factors that eliminate the blood vessel. By adding non-activated PRP, it will become activated. All different kind of interactions with monocytes, with neutrophils will occur in order to re-establish angiogenesis by a huge endothelial cell response. And that's where the different platelet constituents like VEGF, and particular VEGF-A, contribute to building more blood vessels based on the fact that, well, we have a secretion of MMPs and they play a key role ultimately in developing more blood vessels, and ultimately we see different mechanisms across the entire revascularity status based on cell chemotaxis and cell differentiation. So long story short, in order to have re-establishment of blood vessels, to have better blood supply, the influx of nutrition and the removal of waste products, we need to target the combination of platelets with white blood cells. And this has been proven already in a couple of papers, great papers, really indicating how important the roles are of the white blood cells, how important the roles are of the synergy between the platelets and the various white blood cells, as how they are able to regenerate blood vessels in tendon disorders, and even a couple of clinical pathologies have been related to that. Let's make a little move. We've got some time left to adipose. We had a publication. We described as well how adipose-derived preparations can be made, including adipose-derived stem cells. So you see this schematic that's in the article, what it is that is in tissue SVF or nanofat. So these different, very specific adipose cell types can be found in emulsified fat, as you can see it here. And it's already become very clear that tissue SVF, not cellular SVF with monoclonal and enzymatic activation, but tissue SVF has great opportunities for cell differentiation, cell communication, and they might excrete components for the extracellular matrix in response to damaged tissue. So why would you use it as well here? It has been pretty well described by Cesarani that there is a lot of angiogenic potential. There is anti-inflammatory properties. They have been biologically and pathobiologically very well described as what these, tissues, specific adipose tissues can do, including the paracrine effects, looking at immune modulation, antimicrobial effects, and the excretion as well from different chemokines and cytokines. And one of the important stuff that's in there is not only the exosomes, which are present in a lot of fluid and cell types, but as well as in pericytes. Great paper published from my fellow Dutchman, and they concluded, regretfully, the same like we did with PRP, right? The use and the methods to prepare PRP are hugely variable, right? It has been recognized. It doesn't mean there's already a standard, but it has been recognized how important it is. If we're going to use with biological products like adipose, then we're going to do that very, very meticulously. There's a great reference paper as well from Ji Jiang and Zhang, looking at what the true biological, the molecular effects are of adipose tissue. And they have been well recognized, they have been well described, how tissue SVF can modulate the body's immune response system, and how it also affects angiogenesis to the same responses as with leukocyte-rich PRP, looking at it from an endothelial cell response to enhance tissue repair. The beauty of adipose tissue or mesenchymal stem cells from bone marrow is that they can self-replicate. And on their own, they secrete growth factors themselves, and they're able to provide different cells, different stimuli originating from mesodermal, ectodermal, and neuroectodermal cells, ultimately to support or stimulate tissue repair. And lastly, as well with fibroblasts, how they really can contribute to collagenetic activities and build the extracellular matrix. So here is a case I did where we used huge volumes of adipose tissue emulsified, and as you can see we were mixing it with a leukocyte-rich PRP. And based on the density and gravity of both products, you can see that work needs to be done very meticulously. So the mixing, the agitation of PRP with adipose tissue is, it takes time, right? But also here, be aware the quality variances and inconsistencies have been proven with these, different kind of biologics. So what's happening when we mix HD definition PRP with stromal vascular fraction? The benefits are when we mix high definition PRP with stromal vascular fraction is that we enhance any fat graft that has been given to patients. So the fat graft survival rate increases hugely with the avoidance of fat necrosis, while at the same time reducing inflammation by promoting better angiogenetic outcomes, and at the same time be in control of inflammation. It has huge anti-inflammatory properties. So the combination of improved angiogenesis, improved immune modulation, and decrease in inflammation contributes in general to overall better healing processes when that was used. And that was actually one of the rationales for a lot of cosmetic and reconstructive surgeons to use the PRP with adipose, and especially the high definition, because you're going to be working with ratios of cells and you want to have the complete picture in there, not only a plasma type of PRP but also the high density of platelets and white blood cells. Another great paper, already more than 20 years old almost, is from Yoshimura, the godfather of adipose grafting, and he proposed the cell survival theory. The transplanted adipocytes partially survive in response to microenvironmental changes, leading to ischemic adipocyte cell death. So in other words, adding cells to it should prevent it, and this is just a great paper to reference this. So slowly getting to my last couple of slides. Well formulated high density PRP with emulsified adipose tissue known as tissue stromal vascular fracture have a huge biological potential, because there's a lot of synergy, there's a lot of overlap of cellular activities, and therefore they definitely deserve and already have a place in tissue repair and wound healing. So the PRP contributes to the addition of growth factors, right? We will have more signaling proteins in the PRP that are going to help us. Think about the platelet exosomes as well. PRP is known for its pro-angiogenic factors, so these typical PRP features contribute to the well-being over adipose tissue, and therefore to the better proliferation of MSCs and endothelial cells, and the maker matrix, right? So what we know is that MSCs require acellular contact. So if you have MSC just in a syringe and you inject them somewhere, let's say in the petri dish, nothing is going to work. So what's needed is they need a cellular connection. They need to have a cell to matrix connection in order for them to proliferate and differentiate, and also therefore migrate to the different tissue sites. So all of these constituents that we have in PRP really encourage the entire activities of, in this case, adipose-derived adipose-derived stem cells, as well as the plasma. So the plasma matrix by itself contributes to a more sustained release. So by combining different types of biologics, we create a different environment. And that has been published quite a bit in the world of aesthetics and in the world of wound care. And some great comments have been made on the fact, well, listen, if we want to be very successful, we need to come up with some kind of a standardization. We need to know exactly what it is that we are using. And yeah, this, maybe you've seen it in the past, is one of my very successful wound care patients. I had a very, very harsh and very chronic wound, where we then injected adipose with PRP into the periphery of the wound in order to stimulate that area for wound healing, and the same this side for breast reconstruction. And as you can see, it all looks like rich PRP with it. Great papers being published, great references have been given on how to combine PRP and how it works in lower extremity ulcers. And one of my last slides is one of my friends, Dr. Raphael, as well, who mentioned the effect of it. This is another great reference, how adipocyte cells ultimately have a great effect when combined with PRP on outcomes. They noted no side effects, no serious adverse events, stating the safety to use it. This is from Dr. Raphael. It was a great paper. I was very happy to contribute to it. And it mentions, well, the regenerative properties of different biological products, whether it's PRP or PRF or SVF, in order to enhance the wound healing. And also the comment was made very righteously that we need more studies to reflect on what's going to be needed for the future. And in that perspective, I'm looking at my crystal ball for next year, and then we know already a couple of things, right? We know already that high density PRP and tissue SVF are very powerful biological products that can be well combined in an office setting, can be safely used, and we have great potential for tissue repair and functional restoration because of these unique components. Especially with the high density PRP, we're going to bring a lot of healing factors, regenerative factors to the adipose tissue that is at risk, if it was by itself, to die early, right, due to deprivation of oxygen and nutrition. So the big takeaway is that both biological products you can create from the patient's own tissue, the autologous products, have a very synergetic effect. So synergy and synergy is going to come. But overall, I feel where we need to move in 2026 is we need to have realistic goals. We need to pay attention to the fact that we need to validate. We need to pay attention to the fact that we should measure outcomes. Because we keep on turning, we keep on spinning, we keep on swimming with one leg in circles, right? Because we still are lacking standardization, we still are lacking the dosing from a PRP perspective. And I really would encourage all of you, if you want to do research in this field, make sure you have the ingredients in your research protocol to come up with more definitive conclusions based on, well, the cellularity of the products that you intend to use in your patients. Again, Caro, Andre, my dear fellows and friends at Orthoregen, again, it was a pleasure to be with you, and I wish you all the best for 2026. Happy holidays, and I'm open to take any questions at this moment. Thank you so much. Thank you.